start?
Okay, you can start.
Okay, so today, inshallah, I'll talk about the descending and thoracoabdominal aortic aneurysm. So the descending aorta is extended from the left subclavian artery to the diaphragm within the chest, thoracic, and from the diaphragm to the iliac bifurcation, which is abdominal aorta. So the aortic diameter is a 2 to 3 millimeter greater in men than in women. The average, so the descending thoracic aorta diameter is 25.8 millimeter in men and 23.1 in women. The infrarenal abdominal aorta is 19.3 in men and 16.7 in women. The lower abdominal aorta is 18.7 in men and 16 in women. So an aneurysm is defined as a permanent dilation of the artery to at least 1.5 times of its normal diameter at a given location. So it was strongly correlated with the male gender, advancing age, and increased body surface area. Aneurysm that is limited to the chest is classified as a descending thoracic aortic aneurysm, and in the abdomen, and that transfers the diaphragm and extends into the abdomen to any degree is considered as thoracoabdominal aortic aneurysm. The descending thoracic aorta has a slightly higher rate of expansion over time than the ascending aorta, averages 1 to 4 millimeter per year. Chronically dissected aorta tend to dilate at a faster rate than a non-dissected one. Sharp increase in the incidence of aortic complication at aneurysmal diameter greater than 6 centimeters with a 14% combined risk of rupture, dissection, and death. So the etiologies: medial degeneration, atherosclerosis, aortic dissection, connective tissue disorders, aortitis, aortic coarctation, infection, and trauma. These are the etiology for the aneurysm. Thoracic aortic aneurysm are primarily the result of age-related medial degeneration, which is characterized by changes in elastin and collagen that reduce aortic integrity and tensile strength. So the aortic enlargement and aneurysm formation provide a fertile ground for the superimposed intimal atherosclerosis and for further degeneration of the aortic wall. The usual histologic changes in the aging aorta include elastin fragmentation, fibrosis with increased collagen depositions, and medial degeneration. Most aneurysm process medial degeneration usually cause diffuse fusiform aortic dilatation and in some cases produce discrete saccular aneurysm. So the risk factors for aortic dissection and aortic aneurysm overlap to a great extent, but once an aorta becomes dissected, the dissection itself becomes an independent risk factor for the subsequent dilation and aneurysmal changes. Two of the debated types of aortic dissection involve the distal aorta, type 1 and 3, where the dissection and blood flow through the aortic lumen through the false lumen weakens the outer aortic wall, making it prone to progressive aneurysmal dilatation. Genetic mutation and defect can give rise to defective components of the aortic extracellular matrix, leading to aortic aneurysm and dissection. Marfan syndrome is the most common genetic cause of aortic aneurysm, 36%. Other syndromes like also causing aortic aneurysm, Ehlers-Danlos aneurysm, osteoarthritis, and Lewis-Dietz syndrome. So Takawasu arthritis, giant cell arthritis, and rheumatoid aortitis can cause a destruction of the aortic media and progressive aneurysm formation. Aneurysms with the congenital aortic coarctation occur concomitantly with the unrepaired coarctation or years after repair, including endovascular repair. Patients who have had balloon angioplasty are more commonly than in those underwent surgery due to the rupture of elastic fibers during dilatation. Infection can produce a saccular mycotic aneurysms in the wall that has been damaged by the infectious process. Common organisms including Staphylococcus aureus, Staphylococcus epidermidis, Salmonella, and Streptococcus commonly occur along the lesser curvature of the transverse aortic arch or in the upper abdominal aorta adjacent to the organs of the visceral branches. Mycotic aneurysms tend to be unpredictable and rapid growth and rupture. So pseudoaneurysms of the thoracic aorta form as the result of chronic leaks through the aortic wall defect. Leaks contained by surrounding tissue form the wall of the pseudoaneurysm, can develop after aortic surgery, endovascular aortic repair, or invasive imaging, also trauma. Unrepaired blunt and penetrating injuries are the other common cause of aortic pseudoaneurysms, commonly in the proximal descending aorta. So the clinical presentation, commonly patients are asymptomatic, discovered when incidentally, when they are doing imaging study for evaluating unrelated problems, must ultimately produce a variety of symptoms before they rupture. The thoracoabdominal aortic aneurysm produce symptoms in approximately 57% of patients. 9% of patients present with rupture. The most frequent symptom is a back pain between the scapula. When the aortic hiatus pressure, the adjacent structures may cause mid-back and epigastric pain. Compression or erosion of the adjacent organ include stridor, wheezing, cough, hemoptysis, dysphagia, and gastrointestinal obstruction or bleeding. Hoarseness results from traction of the vagus nerve as the distal aortic arch expand and cause recurrent laryngeal nerve paralysis. Thoracic or lumbar vertebral body erosion causes back pain, spinal instability, and neurological defect from the spinal cord compression. Neurological symptoms include paraplegia, paraparesis, or both may result from thrombosis of the intercostal and lumbar arteries, as well as may produce distal impli of the clot or atheromatoous debris that gradually obliterate and thrombose viscera, renal, and lower extremity branches. So imaging. Chest radiographs may show a widening of the descending thoracic aorta shadow, which may be outlined by a rim of calcification, outlining the dilated aneurysmal aortic wall. May also be seen in the upper abdomen. The TTE, the use is to assess the descending thoracic aneurysm is limited by structures and thoracic that weaken or distort the ultrasound signals and compromise images quality. It's used to assess the extent of aortic disease and to exclude additional aortic or cardiac involvement. The abdominal aorta can be visualized to a cheek for abdominal extension of the aortic aneurysm. So CT, widely available and can image the entire thoracic and abdominal aorta, major branches, vessels, and virtually all adjacent organs, showing aortic lumen, interluminal thrombus, presence of aortic dissection, interluminal hematoma, mediastinal or retroperitoneal hematoma, aortic rupture, and pre-aortic fibrosis. MRA, the chief advantage of the MRA are that it does not expose the patient to ionizing radiation, and that is reveal disease within the aortic wall, including intramural hemorrhage. Catheter aortography remain useful in situation where artifact or heavy calcification obscure the area of interest. So these are the recommendations. All patients with a clinical suspicion should go to a CT scan for diagnosis confirmation, and CT angio for thoracic inlet to common femoral arteries should be considered if the patient with for having descending thoracic pathology. For the diagnosis of descending thoracic aorta pathologies, TTE should be considered as a second-line imaging modality when computed when the CT is unavailable. For patient increased risk of contrast-induced neuropathy, the volume expansion with the isotonic sodium chloride or sodium bicarbonate solution should be considered before the contrast. So management, the first step in management of patients with aortic aneurysm is in risk factor control to slow the expansion rate and reduce the risk of dissection or rupture. Non-operative management, strict blood pressure control, cessation of smoking, and at least yearly surveillance with imaging studies is appropriate for asymptomatic patients who have small aneurysms. Symptomatic patients, however, are at increased risk of rupture and warrant expeditious evaluation and urgent aneurysm repair even when the diameter have not been reached. Malperfusion caused by the chronic dissection is also indication for the repair. Degenerative descending thoracic aortic aneurysm or thoracoabdominal aneurysm with superimposed acute dissection are especially prone to rupture and are therefore treated with emergent repair. Indication for operation. In asymptomatic patients, the decision to consider surgical repair is based primarily on the diameter of the aneurysm. Current guidelines recommend elective operation when the aortic diameter exceeds 5.5 centimeters in cases of chronic dissection and 6 centimeters in cases of degenerative aneurysms. Connective tissue disorders such as Marfan syndrome and related disorders. The diameter pairs threshold for operation is lowered. Rapid dilatation rate for only the proximal aorta indicated repair when expansion exceeds 0.5 centimeter per year. It's not unreasonable to apply this threshold to the distal aorta as well. Indication for surgery. Absence of adequate arterial access for the contraindication for aortoiliac conduit graft placement. Absence of proximal or distal landing zone for the endovascular repair. Connective tissue disorders, symptoms related to compression by a large aneurysm to the adjacent structures, to the vertebrae or trachea or esophagus. Two important factors to consider when deciding between open and endovascular repair, which is patient physiological reserve and vascular anatomy. Open repair will have well-documented outcomes and excellent long-term durability, and they allow repair of aneurysms with complex anatomy. The preoperative assessment of the physiological reserve is critical in evaluating operative risks. Many patients have significant comorbidities, chronic pulmonary obstructive disease, coronary artery disease, hypertension, cerebrovascular disease, and peripheral vascular disease as well, are all relatively common in the thoracoabdominal aortic repair. Chronic elevated serum creatinine level, more than 3 milligrams per deciliter, are relatively uncommon in patients undergoing the thoracoabdominal repair and affect 3% of the patients in our experience. So unless they require emergency operation, patients undergo through reoperative evaluation with emphasis on cardiac, pulmonary, and renal function. So the Crawford classification of the aneurysms, which is helping in the extent of aortic involvement, thereby allowing appropriate risk stratification, choice of specific treatment modalities according to the extent of the aneurysms. So we're having 1, 2, 3 extent of aneurysm and 4, of course. So the extent 1, which is when the aneurysm involve most of the descending till the upper abdomen, and 2, which is involving most of the thoracic and till the infrarenal abdominal aorta. 3, when the aneurysm involvement less than the half of the descending thoracic aorta till the infrarenal aorta, and 4, which is mainly involving most of the abdominal aorta. So as we'll say, the repair is involved replacing most of the descending thoracic aorta and the upper abdominal aorta. In 2, repair involved most of all the descending thoracic aorta till the infrarenal abdominal aorta. In 3, in extent 3, repair involved the distal half of the less or less than the descending thoracic aorta and varying portion of the abdominal aorta. In 4, repair involved most of the abdominal aorta. So in 3 and 4, thoracoabdominal aorta tend to pose less operative risk than more extensive distal aortic repair. In extent 1 and 2, thoracoabdominal aorta, although patient-specific diseases such as having a heavy atherosclerotic burden can increase risk even in the lesser repairs. So as we'll say, the preoperative evaluation in cardiac status, impaired myocardial contractility and reduced coronary reserve are common among elderly patients who undergo aortic reconstruction. Cardiac disease has been responsible for 49% of early deaths and 34% of late death after the thoracoabdominal aortic repair. The echo is non-invasive and can satisfactorily evaluate both valvular and bioventricular function. Myocardials can identify regions of myocardium that are reversible ischemic, more practical than exercise testing. With evidence of reversible invasive studies, and in those with significant fraction of 30% or less, coronary arteriography are performed. Patients who have asymptomatic aneurysms and severe coronary artery occlusion, significant left main, proximal LAD. What? Is it working? Hello?
لا يدوس.
الو
ايوه الحين رجعت السلايدز.
رجع؟
تفضل.
Okay. So as said, in patients who's asymptomatic aneurysm and having severe coronary artery occlusive diseases, significant left main, proximal LAD or trivial disease, should undergo myocardial revascularization before the aneurysm repair. Renal status. Preoperative renal insufficiency has been a major risk factor for early mortality throughout the history of thoracoabdominal aneurysm repair. Severely impaired renal function who are not receiving long-term hemodialysis frequently require temporary hemodialysis early after operation and are clearly at increased risk for post-operative complications. Patients are not rejected as a surgical candidate if the basis of renal on the basis of renal function. Patients who have poor renal function secondary to severe proximal renal artery occlusive disease are revascularized at the operation by renal artery end arterectomy, stenting under the direct vision or bypassing graft with the expectation that renal function will stabilize or improve. Because of the nephrotoxic effect of the vascular contrast agent, surgery is delayed, if possible, for 24 hours or longer after CT scan has been performed. If renal insufficiency occurs or worsens after contrast administration, the surgical procedure is postponed until renal function return to baseline or is satisfactorily stabilized. In the pulmonary status, pulmonary complications are the most common form of post-operative morbidity in patients who undergo distended thoracic or thoracoabdominal aneurysm repairs. Patients with the forced expiratory volume greater than 1 and the BCO2 less than 45 are satisfactory surgical candidates. Pulmonary function frequently is improved by smoking cessation, progressive treatment of bronchitis, weight loss, and general exercise program that the patient follow for a period of 1 to 3 months before operation. Hello?
تفضل.
Okay. So open surgical repair. Anesthetic strategies, Songans catheter are routinely used for hemodynamic monitoring. The arterial catheter is placed in the right radial artery whenever the left subclavian artery flow may be interrupted during the aortic clamping. Large pore venous line is necessary for volume return. Single lung ventilation, usually by a double lumen bronchial tube, is necessary for exposure, although this may not be critical in extent type 4 of thoracoabdominal repair. Motor evoked potential are used for spinal cord monitoring. Muscle paralytic must be avoided. Sodium bicarbonate solution is routinely infused to prevent acidosis during aortic cross clamp, and mannitol can be given before cross clamping to enhance renal perfusion. Proximal blood pressure, afterload, and cardiac performance are closely monitored by this one, guys. So there are strategy. Hello.
أنا ما حضرت من الأول. Did you have a consultant? Do you have a consultant with you today?
Yeah, Dr. Fahd Al-Jaber, I think. Yeah.
Okay, ممتاز. Did you want people to ask questions or wait until the end?
You can ask whenever you want to ask. It's okay with me.
Just a couple of slides behind. You mentioned FEV1 of 1.
Yes.
What did you mean by that?
The forced expiratory volume. Okay. It's greater than 1. It's satisfactory for surgical candidates.
Okay. Right. I'm not really exactly sure what did you mean by 1.
I think it's a mistake.
Anyway, for details, I got the devil's in the details. يلا كمل معلش.
Okay. So there are strategy for the spinal cord and visceral protection during descending and thoracoabdominal aneurysm repair. So on all the extent or on all the aneurysm types, moderate heparinization, 1 milligram per kg, permissive mild hypothermia, 32 to 34 degrees Celsius, aggressive reattachment of the segmental arteries, especially between T8 and L1, perfusion of renal arteries with the 4 degrees Celsius solution when possible, sequential aortic clamping when possible. In extent 1 and 2 repair, cerebrospinal fluid drainage and left heart bypass during proximal anastomosis, selective perfusion of celiac axis and superior mesenteric artery during intercostal and visceral anastomosis. So, as said, heparin potential the potential benefit of the heparinization include preserving the microcirculation and preventing embolization. Administration of the heparin before aortic clamping on the start of the left heart bypass. After this, small heparin dose is administered. The ACT generally range from the 220 to 270 seconds. Hypothermia decrease the metabolic demand of tissue, and the protective effect of spinal cord are well accepted. Temperature is allowed to drift down to the nasopharyngeal temperature to be 32 to 33 degrees Celsius or 34. After the aortic repair, rewarming can be accomplished by irrigating the thoracic and abdominal cavities with a warm saline. Many clinicians avoid using this approach, principally because of the associated risks of coagulopathy, pulmonary dysfunction, and massive fluid shift. In left heart bypass, effectively unload the proximal circulation during aortic occlusion and maintain adequate perfusion of distal vital organs, thereby reducing early mortality and renal failure. Spinal protection, paraplegia remain an index complication specific to both distal aortic surgery and endovascular repair. Spinal cord ischemia associated with interrupted distal aortic blood flow following proximal aortic clamping and the intraoperative loss of intercostal and lumbar arthritis, reperfusion injury, and embolic debris. With modern operative techniques and spinal adjuvant, paraplegia rate in aortic centers are currently 1 to 5%. So for the spinal protection, CSF drainage, was that it would enhance spinal perfusion by decreasing the pressure on the cord during aortic cross clamping. It is a class 1 recommendation, level P, for both open and endovascular repair in patients at high risk of developing paraplegia. Non-risk, including intracranial bleeding, pre-spinal hematoma, meningitis, and spinal headaches. The intrathecal catheter is placed through the second or third lumbar space preoperatively after induction of the anesthesia and is maintained to 1 to 2 days postoperatively in the intensive care unit, keeping the pressure between 8 to 10 millimeter mercury during the operation and between 10 to 12 during the early postoperative period. Once the patient are awake and neurologically intact, the CSF pressure are allowed to raise to a high range of 15 to 18. To prevent intracranial hemorrhage, avoid draining more than 25 milliliter per hour. So second spinal protection methods, segmental artery reattachment and sequential graft clamping. Large arteries with a little or no pack bleeding are considerable as important. Patent segmental arteries from T1 to L1 are selectively reattached as a patch to one or more opening on the graft. Here. So when none of these arteries is patent, endarterectomy of the aortic wall and removal of the calcified intimal disease can be considered. After the reattached, the proximal clamp is often moved down the graft to restore the intercostal perfusion. Sequential clamping restore perfusion to the proximal branches vessels and will decrease the ischemic time to the spinal cord. As we are doing this procedure, additional time needed to be performed. The possibility of imply is to dislodge the branches lead to localized ischemia is rare. Third method is spinal cord monitoring. Somatosensory evoked potential, motor evoked potential, and near infrared spectroscopy. Monitoring have been used for intraoperative assessment of spinal cord function because of the motor function of the anterior horn of the spinal cord is more susceptible than the posterior horn to ischemic and the infarction. The motor evoked potential changes are a sensitive indicator of spinal cord ischemia, and it is a class 2B, a level C to be used. Regional spinal hypothermia, direct infusion of cold perfusate into the epidural or intrathecal space and by intravascular cold perfusion of isolated thoracic aortic segments with the expectation that the intercostal vessels will deliver the cold perfusate to the spinal cord. Patient who underwent extent 1, 2, or 3 repair, the incidence of spinal cord ischemia injury was reduced from 19.8 to 10. So these also the recommendations in using the methods of spinal cord protections. Collateral network concepts. The anterior spinal artery is only one component of an extensive paraspinous and intraspinal collateral vascular network. This network will provide perfusion when segmental arteries are sacrificed during the thoracoabdominal aortic aneurysm repair. Collateral network concepts refute the extent of dominant intercostal and lumbar arteries and imply that reattaching select intercostal arteries is largely unnecessary. Instead, the network of small artery provides sufficient perfusion of the spinal cord. So the post-operative management remain critical to spinal cord protection. Adequate blood pressure, preload, and cardiac inotropic state are carefully maintained to keep spinal perfusion sufficient. Delayed paraplegia can arise hour to days after aortic surgery. strategies to reverse fluid-inducing systemic hypertension, placing a CSF drain, decreasing the CSF pressure, administrating cardiac inotropes, mannitol or steroids, correcting anemia, and preventing fever. Recovery from paraplegia is possible and there, but if cord function does not return promptly after these measures are taken, such a recovery is not likely. So we will now talk about the renal protection. Post-operative renal failure remain an important complication and is predictive of mortality. Distal aortic perfusion with the left heart bypass provide renal perfusion during proximal anastomosis. Providing continued renal protection is valuable. Once renal vessels are exposed during distal repair, the renal arteries can be directly perfused with a cold perfusate. Recommendation of using a cold renal perfusate is class B level B. Visceral protection, distal aortic perfusion by left heart bypass provide flow to the mesenteric branches during repair. Once the visceral origin are exposed, then balloon perfused catheter that are placed within the organs of the celiac and superior mesenteric arteries and attached to the left heart bypass circuit via a Y line from the arterial perfusion line. Reducing hepatic ischemia in this fashion may decrease the risk of post-operative coagulopathy, and reducing bowel ischemia may decrease the risk of bacterial translocation. So the operation techniques, incisions and aortic exposure. The patient is placed in a modified right lateral decubitus position with the shoulder placed at 60 to 80 degrees and the hips rotated 30 to 40 degrees. In cases of extent 1 and 2 repairs, which require access to the left subclavian artery, distal and distal arch in the upper chest, the approach is through 6th intercostal space, 5th to 6th actually, intercostal space, and rarely the upper or lower ribs may be divided posteriorly to achieve additional proximal or distal exposure. In extent 3rd repair, aneurysm entering through the 7th or 8th intercostal space will allow adequate access. In the cases of 4th extent, the approach via a straight oblique incision through the 9th or 10th intercostal space. So the aneurysms limited to the descending thoracic aorta are approached through a full posterolateral thoracotomy. If the aneurysm predominantly involve the upper portion of the descending thoracic aorta, the 5th intercostal space provide better access to the distal aortic arch. So exposure of the distal descending thoracic aorta is enhanced by dividing the costal margin without dividing the diaphragm. The full thoracoabdominal incision extends from the left posterior chest between the scapula and the spine, crosses the costal margin and transfer oblique to the umbilicus. The length and the level varies according to the anatomy of the aneurysms. The incision is gently curved as it crosses the costal margin to reduce the risk of tissue necrosis at the apex of the lower portion of the musculoskeletal tissue flap. So in cases of extent 4, aneurysms are approached via a straight oblique incision through the 9th or 10th interspace. Ending the incision distally at the level of the umbilicus will allow access to the aortic bifurcation. The incision can be extended toward the pubis if iliac aneurysms also require repair. For thoracoabdominal access, the diaphragm is divided partially or completely in a circular fashion to protect the phrenic nerve and preserve as much as of the diaphragm tissue. So the cross of the diaphragm is divided at the hiatus, and 3 to 4 centimeter rim of the diaphragmatic tissue is left posterolateral to facilitate closure. The retroperitoneum is entered laterally to the left colon, and medial visceral rotation is performed to expose the aorta. Dissection plane to the anterior of psoas muscle, and the left kidney, left colon, spleen, and left ureter are retracted anteriorly and to the right. Abdominal aortic segment is approached transperitoneally. Opening the peritoneum permits direct inspection of the abdominal viscera and its blood supply. Entirely retroperitoneal approach can be used in patients with abdominal surgery history. The aorta is approached laterally to avoid injury to the mesenteric vessels and the abdominal organs. The left renal artery is identified, but generally does not require mobilization, and the left renal vein courses posteriorly around the aorta. This branch may be ligated and divided as needed. Dr. Fahad? Hello? If you have any comments, you are more than welcome to give.
Sure. Maybe you can keep the comment at the end if you wish.
Okay.
Unless you have any question, we can interrupt.
Okay, sure.
Yeah.
So now we'll talk about the proximal anastomosis for the descending thoracic aortic aneurysm and extent 1 and 2 thoracoabdominal aortic aneurysm repair. Options for proximal control include applying a proximal aortic clamp distal to the left subclavian artery, or applying an aortic clamp between the left subclavian and left carotid artery, and applying a separate bulldog clamp to the left subclavian artery. Applying an aortic clamp to an existing graft during an elephant trunk operation in cases of, and open anastomosis under hypothermic circulatory arrest with full bypass when an aortic clamp cannot be safely applied. The decision is based on the anatomy of the aneurysm. So, in aneurysm suitable for aortic clamping, the distal aortic arch is gently mobilized by dividing the remnant of the ductus arteriosus. The vagus and recurrent laryngeal nerves are identified. Vagus nerve may be divided below the recurrent nerve to provide additional mobility, thereby protecting the recurrent nerve from injury. Preserving the recurrent laryngeal nerve is important in patients with chronic obstructive pulmonary disease and reduced pulmonary function. So if the aneurysm encouraged upon the left subclavian artery, clamping proximal to the left subclavian artery should be anticipated. They then circumferentially mobilized to enable placement of a bulldog to the left subclavian artery. After heparin is administered, proximal clamping is applied to proximal descending thoracic aorta or the distal aortic arch between the left common carotid and left subclavian arteries. When the left heart bypass is used, it is initiated at a flow rate of 500 milliliter just before the proximal aorta is clamped. After the clamp is applied, the left heart bypass increased to 2 liters per minute. And second distal aortic clamp is placed between T3 and T7. The aorta is transected 2 to 3 centimeters beyond the proximal clamp and is separated from the esophagus to allow the surgeon to place full thickness sutures in the aortic wall without injuring the esophagus. After aorta is open, patent repair intercostal artery are over soon. Yeah, so a 22 to 24 millimeter Dacron graft is used in most patients. Proximal anastomosis is performed with continuous sutures. So in repairs of large aneurysms at the distal arch or aneurysm with enormous size contained rupture, or in a redo operations in which safe dissection and clamping are not possible, an alternative strategy is total bypass with a hypothermic circulatory arrest performed. Arterial inflow, cannula in the distal aorta, or you can use FIM to FIM, Venous drainage cannula into the left femoral vein till the right atrium. Circulatory arrest is initiated and aneurysm is opened. Direct antegrade cerebral perfusion into the left carotid artery via a separate balloon catheter arising from the arterial limb of the circuit. Proximal anastomosis performed after completed a wash limb from the arterial line connected to the side branch of the graft, then de-aired and clamped. Pump flow to the upper body is resumed and aortic repair is completed. Elephant trunk repair preferred in patients with extensive aneurysmal disease involving the ascending aorta, aortic arch, and descending thoracic. Last week, one of the consultants talked about the elephant trunk. So the presence of the elephant trunk graft within the descending aorta allow secure clamping of even very large aneurysms distal to the left subclavian artery. So in cases of reversed elephant trunk repairs in patients presented with descending thoracic or thoracoabdominal aortic aneurysm that has ruptured causes and symptoms are considerably larger than the ascending aneurysms. So the descending or thoracoabdominal is treated during the initial operation, and the ascending aorta and the transfer aortic arch are repaired as a second procedure later on. So the intercostal patch, anastomosis, and completion of repair. After the proximal anastomosis is completed, the left heart bypass is discontinued and the distal aortic clamp is removed. The aortic clamp is moved down into the graft, sequential grafting, and the left subclavian artery clamp is removed. This restores blood flow to the left vertebral artery and to the spinal collaterals. For repairs that extend to the diaphragm or beyond, patent lower intercostal arteries are selected and reattached to an opening cut on the graft. If the aortic tissue is particularly friable, a separate 8 millimeter graft can be attached in an end-to-end fashion to the selected intercostal vessels. Yeah. In cases of descending thoracic aneurysm repair, the distal anastomosis is then performed as an open distal anastomosis. For aneurysm arising from the chronic dissection, the membrane between the true and false lumen is fenestrated distally to ensure that both lumen are perfused. Visceral branch vessels anastomosis. In patients with a thoracoabdominal aneurysms, after the descending thoracic aorta repair is completed, the remainder of the aneurysm is open longitudinal. The origin of the visceral and renal branches are identified. Perfused is intermittently delivered to the renal artery via a catheter. In patients receiving a left heart bypass, balloon cannula placed in the celiac and superior mesenteric arteries so that selective visceral perfusion can be delivered from the pump circuit. Subsequently, the celiac, superior, mesenteric, and renal artery are reattached. In cases of extent 1 repair, the reattachment of the visceral arteries is often incorporated into the pivotal distal anastomosis. So, in cases of extent 1 repair, the attachment of, as I said, visceral arteries is often incorporated into pivotal distal anastomosis. In extent 2 and 3 repair, the visceral artery origins are reattached to one or more oval opening on the graft. Distal aortic and iliac anastomosis, when the thoracoabdominal aorta aneurysm extend below the renal arteries, a distal anastomosis is performed near the aortic bifurcation. In patients with iliac artery aneurysms, bifurcation graft is sewn into the end of the straight graft, then anastomosed to common iliac, external iliac, or common femoral artery, depending on the extent of the disease. So now we're coming to the closure. After all clamps are removed, Heparin is reversed with protamine sulfate. Hemostasis is achieved. The renal, visceral, and peripheral circulation are assist. The bowel, spleen, and liver all are assist for adequate perfusion. 2 posteriorly located thoracic drainage tubes and in a closed suction retroperitoneal drain are placed before closure. The diaphragm is closed with a continuous suture. So in the early post-operative care, blood pressure. So blood pressure management is critically and must be balanced between hypertension and hypotension. Hypertension that can cause bleeding and hypertension which will cause paraplegia and paraparesis. Early post-operative period, hypertension may disrupt the suture lines and causing a severe bleeding or pseudoaneurysm formation. Using nitroprusside or intravenous beta blockers, antagonists, and intravenous calcium channel blockers to keep the MAB pressure between 80 to 90. In patients with severe fibril aortic tissue, such as with Marfan syndrome, the target MAB is to be between 70 and to 80. Complications that are commonly associated with an increased risk of death include paraplegia, renal failure, respiratory failure, cardiac events, and bleeding. Patients who have undergone repair remain at risk for developing new aneurysms in other aortic segments or in reattachment patches, progressively weakening of aortic tissue at suture lines. And at suture lines can lead to pseudoaneurysms. Patient should undergo annual CT or MRI imaging of the chest and abdomen. This strategy of lifelong surveillance is especially important in patients with genetic disorders. So Dr. Fahd, if you have any comment for the operations technique.
Thank you, Dr. Abdurrahman. For sure, it's a very interesting operation and very complex. You have to have good preparation, pre-operative, intraoperative, and post-operative care. Most of those patients, unfortunately, they are very high risk. So you have to take care of each organ perfusion during the procedure. The most important is the heart and the brain. But if any organ gets ischemia, he might give paralysis due to spinal cord ischemia, renal dysfunction due to kidney malperfusion, or even bowel ischemia. So each step is very critical and very important to be tackled. You mentioned a lot of details, mashallah, regarding the preparation, either pre-operative or intraoperative, and the precaution should be taken. So what I can advise, because all of this is written, so there is a lot of videos on the YouTube. If anyone interested, just to check, and I can send it to Malik or to you by WhatsApp to explain the steps of the procedure. Each type has its own complication rate and success rate. Mainly we are talking here about the descending thoracic aneurysm or thoracoabdominal aneurysm, which needs a collaboration between a lot of specialties. So it is a multidisciplinary approach. So you need a good cardiac anesthetist, you need a cardiac surgeon, you need a vascular surgeon, you need someone who's very good in spinal cord drainage. So all this precaution needed to prevent any complication. So technically, it is difficult. It's a longer procedure. If you are interested, just see the videos. There is a lot of videos on the YouTube with 1 hour. You can pick up all the precaution for different types. I don't know if any one of the guys has any question to be clarified or to be just superimposed.
Yeah. So is there any question, guys?
Good afternoon. يديك العافية دكتور فهد.
الله يعافيك. هلا.
البار معك. My question regarding when I have to use the left heart bypass in such operation. يعني in which type or when I have to use a left heart bypass?
Oh, it depends on the extension of your aneurysm. If it is type 2 or 3, it will be from the left subclavian down to the diaphragm. So if you are going to take a lengthy procedure, you are not going to take all the precautions, subsequential clamping, iced or cold saline perfusion to the organs. Is better to use the left side bypass. So as you know, most of our patients are obese. So those patients per se, they come in bigger size. I don't know why, either Marfan or obese patient as part of their risk factors. So it's better to go for bypass to protect the whole body, because you need to go for hypothermic maneuver. You need to perfuse the kidney. The kidney cannot stand for more than 1 hour. Bowel and lower limb can stand for almost 4 to 6 hours without reperfusion. Brain, as you know, 4 minutes, and patient will have permanent brain damage. So it's better to go for left-sided bypass with an expert perfusionist, so to distribute blood between the upper body and the lower half to exclude the area where you are going to operate.
Okay, thank you.
واضح ولا نتكلم كثير؟
No, it's clear, yeah.
Okay. Any other question?
Yes, guys.
تفضل. Just to emphasize again, if we are expecting those kind of a procedure will take longer time. So I think a lower number done per center. So if we have high numbers, so you can do a quick procedure and do your anastomosis like mentioned by Dr. Abdurrahman, which is you take the island of the vessel, like the intercostal vessel, or you can take island of celiac, superior mesenteric artery, and renal in one island, and you anastomose it quickly. But this also have to have precaution with ice saline and hypothermia, and also spinal cord drainage. So even with expert surgeon, this procedure would take at least 4 to 6 hours. So in high volume center, maybe they don't do the left side bypass. But in our case, it's not very common to have. Maybe we are seeing 1 or 2 cases per year. So it's not we are not considered in the region, in Middle East, I think, as a higher center cases for thoracoabdominal aneurysm. So routinely, we are using the left side bypass.
Yeah, since the left heart bypass having advantage, which is reducing the stroke from the aortic cannulation or reducing aortic dissection, as well as pulmonary dysfunction post-operatively. As well as, yeah, you mentioned some of the disadvantages of the left heart bypass. So, yeah, guys, is there any other questions for the Fahad?
Just to comment also, Abdurrahman, mashallah, you mentioned all the details starting from the presentation, etiology, pathophysiology of the disease itself. But just to enforce a point regarding the guys, you have to differentiate between the causes of or the etiology of like dissection versus degenerative aneurysmal disease and the traumatic. So each one has a special management or intervention. As you mentioned, the endovascular technique is good to be implemented in some of the cases, but it needs a special situation like a proximal and distal landing zone, sizes of the femoral, of calcification on your axis. these things need to be tackled before going for endovascular technique. The endovascular technique usually has lower risk of spinal cord paralysis or ischemia. So if we can do the endovascular technique for those cases, will be fine and good. If you cannot, you can do sometimes a hybrid procedure. So you can do like debranching from the ascending aorta to the major neck vessel and upper subclavian. Then you cover the rest of the aneurysm or the dissection or even the pseudoaneurysm with a covered stent. We call it hybrid procedure. So you are doing both type of intervention, open and endovascular. Other techniques, we have like fenestrated graft, which is need time to be manufactured because it takes like 13 to 14 weeks to be ready, which is already there is a measured by the patient or is custom fit for each patient. So you have an opening at each branch. Other techniques also, there is a branched endovascular graft, which has already made tube graft arising from the main body of the graft. This is available, but it needs a special measurement and special sizing. So if you have the technology and you have the training, try to use the minimal invasive procedure if it is applicable. If not, open procedure is lengthy procedure, has higher risk of mortality, morbidity, but it is very fun to have or to see and to do. Any other questions?
Yeah.
I don't know if you want to conclude or...
So, as said, patient should undergo annual CT or MRI imaging of the chest and abdomen. This is a strategy of lifelong surveillance, especially in patients with the genetic disorders. And thank you, and special thanks to Dr. Fahad for his answerings and talking. So, Murtada?
Thank you very much, Abdul Rahman. Thank you, Dr. Fahad. We can, I think now we can proceed to our next lecture.
Mm-hmm. Okay.